Hello. Today we will give you information about gestational trophoblastic. Let's start gestational trophoblastic disease, grape pregnancy. The disease commonly known as grape pregnancy is defined as gestational trophoblastic disease in medicine. In this article, it will be described under the title of gestational trophoblastic disease, GTD. GTH is a disease picture associated with many pathological developments, including mole hydatiform, grape pregnancy, invasive mole, chorocarcinoma, and trophoblastic space tumor originating from placental tissue made of the child. There are many types. The disease that occurs when GTH does not heal is called gestational trophoblastic tumor, GTT. GTT often occurs after grape pregnancy, mole hydatiform. Rarely, it may also occur after miscarriage and normal pregnancy. Pathologically, GTT is often seen in two forms as invasive mole and choriocarcinoma. Today, GTT is recognized as an easily treatable disease with complete cure. There are several reasons for this. First, they secrete an important tumor marker such as HCG. In all women with GTH, the blood level of the substance called HCG rises above normal and becomes very high. Secondly, the factors that determine the prognosis of the disease are well known. The third and most important reason is that these tumors respond very well to chemotherapy. GTH is a disease associated with pregnancy. Therefore, it is common and an important health problem in societies with high fertility rate like our country. Although it varies from country to country, it is seen at a rate of 1 in every 1,000 pregnancies. Factors associated with GTH: 1. Race: 2. Nutritional characteristics: 3. Age: 4. Number of pregnancy: 5. Past mole hydatiform: 6. Birth control method: 7. Cigarette mole hydatiform MH, is popularly known as grape pregnancy. It is the most common GTH and responds best to treatment. There are two types: incomplete, partial incomplete. In incomplete mole, there are intact parts of the fetus in the uterus other than the diseased area. In complete mole, the uterus is shaped like a grape pregnancy and there are no fetal tissues. In complete mole, there is a genetic structure belonging to the father. Clinic 75–80% of mole cases present to the clinic with abnormal bleeding. In a significant proportion of patients, abnormal bleeding is observed after menstrual delay. For this reason, the disease is often considered as miscarriage, abortion at the beginning. On gynecological examination, the uterus may be larger than the expected gestational week. Thanks to ultrasonographic examinations, a large proportion of mole cases can be recognized without causing complaints. Diagnostic pregnancy test is positive in mole cases. The levels of the substance HCG in the urine and blood are always significantly increased. Ultrasonography is of great benefit in the early diagnosis of MAH as well as in the early diagnosis of GTT cases. USG can detect 80% of complete MAH cases and 30% of partial mole cases before histopathological evaluation. From another point of view, in approximately half of the mole cases, USG findings do not resemble a mole. Therefore, any abortion material performed to evacuate the fetus in the uterus should be sent to the pathology laboratory. In addition to USG, imaging modalities such as CT and MRI can also be used in the diagnosis, but these modalities should be used to detect the foci of spread of GTTs. Treatment of mole hydatiform. As soon as MH mole hydatiform grape pregnancy is diagnosed, the uterus should be evacuated as soon as possible. The mole evacuation should be performed by vacuum curettage, and the inner region should be completely cleaned from the grape pregnancy. After mole evacuation, patients should be followed up at intervals of 7–10 days until the blood HCG level is normalized. The purpose of HCG follow-up is to identify cases of ongoing GTH, in other words, cases of gestational trophoblastic tumor, GTT. HCG blood level is elevated in some ovarian tumors and in normal pregnancy except in patients with GTT. The disease is considered cured when the blood HCG level is normalized in HCG measurements performed after mole evacuation. However, patients should continue to be followed up with HCG measurements for 1 year, because the disease may recur during this period. If the HCG level is normal after 1 year, MAH is considered to be completely eliminated, and the disease is considered to be completely cured. In this case, the patient is removed from follow-up. After the hormone chorionic gonadotropin HCG is normalized after mole evacuation, HCG measurement intervals are increased from once a month for the first 6 months to once every 2 months for the next 6 months. The patient should not become pregnant during this period. The use of birth control pills is recommended to prevent pregnancy. In HCG controls performed after mole evacuation, if the HCG blood level remains at the same level or increases, the disease is called persistent trophoblastic disease or gestational trophoblastic tumor. Gestational trophoblastic tumor. Gestational trophoblastic tumor, GTT, usually occurs after a molar pregnancy, but can also occur after abortion and normal pregnancy. GTT can be seen in two forms: non-metastatic, and metastatic, metastatic. Metastatic GTT occurs after 4% of MH cases. It can also occur after other pregnancies. Metastatic ones may cause different complaints according to the site of metastasis spread. For example, coughing, coughing up blood, and shortness of breath occur in patients with metastatic metastases to the lungs. Bleeding occurs in patients with metastatic metastases to the birth canal. And neurological complaints such as headache, visual disturbances, and dizziness occur in patients with metastatic metastases to the brain. In 80% of GTT cases, spread is seen in the lung, in 30% in the vagina, in the labor tract, in 20% in the pelvis, in the groin, in 10% in the liver, and in 10% in the brain. Diagnosis and histological types in GTT. As mentioned above, no change in blood HCG levels for 3 weeks or an increase in blood HCG levels for 2 consecutive weeks in HCG controls performed after MH evacuation is considered abnormal. In this case, the disease is called persistent trophoblastic disease or gestational trophoblastic tumor. GTT is diagnosed in patients whose HCG does not fall within normal limits over a period of more than 6 months, and who have a pathological diagnosis of karyocarcinoma. The average probability of developing persistent GTT after a molar pregnancy is 20%. GTTs have different subhistopathological types other than karyocarcinoma. GTT malignant, GTH1, invasive mole 2, choriocarcinoma 3, placental space tumor 4, epithelioid trophoblastic tumor 5. Others invasive mole is when MH is seen in the uterine wall. It is a type of GTT that does not spread. It is a type of GTT with a high probability of responding to treatment. With the widespread use of ultrasonographic examinations, invasive mole can be diagnosed earlier and more easily. Choriocarcinoma. It is a type of GTT with a very high probability of dissemination. It spreads primarily through blood vessels. Due to this feature, it can spread all over the body. Common sites of spread are liver, labor tract, and brain. It may occur after great pregnancy as well as after miscarriage and normal pregnancies. As mentioned above, there are many subgroups of GTT other than choriocarcinoma. However, since these are very rare, they will not be discussed here. Clinical evaluation. In patients diagnosed with GTT in any way, the first thing to be done before treatment is to investigate whether the disease has spread outside the uterus. Most of the time, it is not necessary to take a biopsy, piece, during this investigation. Important information about the location and size of the disease in the uterus can be obtained with ultrasonographic research performed after the gynecological examination. In the second step after these examinations, lung and abdominal cavity tomography is performed to look for areas of spread, if any. MRI can also be taken for this purpose. After these investigations, the stage prevalence of the disease is determined and treatment is given according to the stage. GTT treatment. In more than half, 75% of the cases with GTT, the pathological tumor type is invasive mole. However, the choice of treatment in GTT is not related to the pathological type. In other words, tumor histology does not affect the treatment modality in GTT. As mentioned above, after the diagnosis of GTT, the extent or stage is determined by examination and films and treatment is initiated. GTTs are treated with chemotherapy. These tumors respond very well to chemotherapy drugs. However, radiotherapy and surgery may be necessary in some special cases. If the disease is only in the uterus and has not spread elsewhere, or if it has spread only to the lung, treatment is started with one of the chemotherapy drugs called methotrexate and actinomycin D. If the disease has spread somewhere other than the lung, if it does not respond to single drug chemotherapy, and in some special cases, treatment is performed as multi-drug chemotherapy. If the disease has not spread to the liver and brain before treatment, 80–90% of patients recover. In tumors that have spread to these organs, the cure rate is around 60%. Follow-up after treatment. More than 90% of GTT cases recover completely after treatment. Recurrence rates after treatment are between 4% and 8%. A significant proportion of recurrences are seen within 18 months from the time of complete response. In other words, the normalization of HCG. Recurrences are more common in high-risk GTT patients and karyocarcinomas. Thanks for watching.